Good afternoon, everybody. Welcome to ACEs Aware Kings County, our Network of Care event. This is our third event, and we are very excited to have everybody here. I'm excited to have a large contingent from Kings County, and we're very excited to have Dr. Liu as our guest speaker today, discussing ACEs awareness and social justice. My name is George Yagetic, and I'm the Training and Engagement Facilitator. Throughout this session today, we encourage you to stay aware of not only what's going on with the information being passed on, but aware of your body. Begin to check in with yourself. Notice how your felt state changes. As we begin talking about topics such as ACEs, trauma, and toxic stress, you may notice changes in your body, just something to be aware of. I think it's important that as we go on with talking about ACEs, toxic stress, and traumatic issues, that we understand how it affects our bodies just secondarily. Very important. A couple of housekeeping items. This webinar is being recorded. Slides will be made available to you at the conclusion of our training event. Please keep your microphone on mute until we begin taking questions. The chat feature is always available for questions. So as your questions filter in during the course of the presentation, please put them in the chat feature. We will pull them out at the end when questions are being taken live. If you're asked to unmute yourself and verbally give your question, please do so. We'll have some time for those verbal questions afterwards. If you're having issues with connecting to the webinar, please call in and mute your phone. And to start off with, I'd like you to please introduce yourself with your name and your organization in the chat feature so that we can have an accurate record of who we have in attendance. We'd like to know everybody that's here. One fun feature that we're going to do is at the end of the presentation today, if you make it all the way until the end after our 211 presentation, we are going to be doing a raffle for a small prize. If you stick around until the end, you'll be available for the raffle, but you need to be here when we do call your name. So keep that in mind. Stick around till 3:30. That's what time this event will go to. Lastly, please check your Zoom name and ensure it has the correct name to identify you, first, last, and if you want to put your pronouns. To begin with, I'd like to not only introduce myself, but the other ACEs Aware grantee collaborators. ACEs Aware King's collaboration with funding from ACEs Aware is a collaboration of California Health Collaborative, Kings County Department of Public Health, King's Partnership for Prevention, and King's United Way. We very much appreciate the work of our partners who have committed to moving this work forward to improve the health and well-being of individuals, families, and the communities in which we live. So at this point, I'd like a quick round of introduction for our collaborators so that you can know who's who and from what organization they hail from. I'll go ahead and bring in first, if we could have Karina.
Hello, everybody. My name is Karina Casares, and I work with King's Partnership for Prevention. I'm the office administrator, so I do a lot of the logistics. And if you get emails, you're probably getting it from me. So if you have any questions, you can always email me at the kpfp.administrator@gmail.com. So thank you for being here.
Awesome. Thank you, Karina. Cameron, would you like to introduce yourself?
Hello, everyone. I am Cameron. I am the KPFP Communications Coordinator. I'm very excited that you're all here and very excited to have Dr. Liu with us.
Awesome. Thank you, Cameron. And Erica, would you like to introduce yourself, please?
Good afternoon, everybody. My name is Erica Lopez. I'm the 211 coordinator at Kings United Way. I'm very excited to talk to you all about community information exchange and 211 Kings County. Thank you.
Awesome, thank you. Just a quick run through of those people who are in the collaboration who are not here today. We have Everardo Legaspi, who is our program manager at Kings County Health Department. Daisy Lopez is our Senior Director here at California Health Collaborative. Linda Baggio is the Program Manager of the California Health Collaborative. Nanette Villarreal is the Executive Director at Kings United Way. And finally, we've got Julie Lafie, who is the Executive Director at King's Partnership for Prevention. At the end of the presentation today, we are going to have an opportunity for everybody here to introduce themselves and to share a little bit about their takeaways from this event. So keep that in mind for the end. The California Surgeon General has set a bold goal to cut ACEs in half in one generation, and this effort in part is in part of Governor Gavin Newsom's California for All initiative. The mission is to change and save lives by helping providers understand the importance of screening for adverse childhood experiences and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. And finally, it is my great honor today to introduce our guest speaker. Dr. Sabrina Liu is a clinical psychologist and a postdoctoral fellow at the UC Irvine Conte Center. Her scholarship focuses on understanding, addressing, and preventing exposure to trauma and adversity among children and families, particularly those from culturally diverse and underserved backgrounds. Sabrina has published and presented on ACEs, their assessment in primary care, and their links to health equity and resilience. Her works have also addressed community and mass violence, disaster, mental health, forced migration, racism, and child mental health interventions in low resource settings, both domestically and abroad. As a trauma-informed clinician, she has worked with youth in hospitals, schools, and community mental health centers. Sabrina earned her PhD from the Department of Counseling, Clinical, and School Psychology at UC Santa Barbara and completed her APA accredited doctoral internship at Cambridge Health Alliance, Harvard Medical School. At this point, I'm very honored to introduce Dr. Liu. It's a technical change here. Dr. Liu, if you'd like to share your screen and begin the presentation. Thank you all for being here.
Yeah, thank you so much for that introduction. Let me just get this set up. All right. You can see my screen? Seeing nods? Okay, great. So let's just make that small. Okay. So I'm really excited to be here and talk with all of you. Just from looking in the chat, it seems like there's such a wide range of expertise. So that's really exciting. My goal for today is to talk about how we can better understand ACEs through looking at them with a socio-political lens. And then with that context in mind, I want to discuss some challenges to health equity that I think the ACEs movement brings, and then also talk about ways in which I believe it can be utilized to promote health equity and social justice. And just to give like a quick disclosure statement, the views expressed in this presentation are solely mine and don't necessarily represent the position of any institution that I'm affiliated with. Okay, so I'd like to start off with just a quick refresher on ACEs in general. And I think it would be helpful to just kind of know the audience's familiarity with ACEs and their impact on health. So I think we have a poll that we're going to try to administer. Oh, there we go. And I can see the results. Can everybody see the results? Okay. Well, 88% of people have voted. Did you want to say something, George?
Can you see the results?
I can see the results, yeah.
Okay, good.
Yeah. So it looks like we have a range. There's very few people that are not at all familiar, 50% of people somewhat familiar, 44% of people very familiar. So for the people that are very familiar, bear with me while I just kind of just spend a bit of time going over the more basic information. So see. Can I close that? Okay, perfect. So historically, ACEs, which stands for Adverse Childhood Experiences, has included these 10 items within these 3 broad domains of abuse, neglect, and household dysfunction. So specifically, experiences of childhood physical, emotional, or sexual abuse, experiences of physical or emotional neglect in childhood, or having a family member with mental illness or with substance abuse, or having a family member incarcerated, or experiencing domestic violence in your home, or having parents that are separated. So this collection of adversities really first became known as ACEs through this original study that was done by the CDC and Kaiser in the late 1990s. And they looked at over 17,000 participants. And it was really the first study to examine all of these categories together, along with later life health outcomes. So what they found was really shocking to the field and to the general public for a couple reasons. The first reason being that ACEs were way more common than anyone realized. So in their sample, about 2/3 of their sample had at least one ACE, and 12.4% had 4 or more ACEs. And that was something that we didn't know up until that point. You know, it's understandable. These adversities are challenging to talk about. They can be traumatic. They can come with a lot of shame and stigma. So unless we're specifically asked about this, we're not necessarily going to volunteer that information. The second thing that they realized that was really shocking was how strongly related ACEs were to later life health outcomes. And they were related to a whole range of health outcomes in this dose response fashion. So when I say dose response fashion, what I mean is that for every additional ACE that a person has, their risk increases exponentially. So that's what the graph on the left here is just trying to illustrate. And so these results have been replicated and expanded by additional research since the original study. So we now know that not only are ACEs linked to poor health outcomes like obesity and diabetes, they're also related to health risk behaviors like smoking or alcoholism, and then also what researchers have termed life potential or life achievement outcomes like graduation rates or academic achievement. And just to give an example of what that dose response relationship really looks like, you can see in this box on the right, just some statistics about a person's increased risk for various outcomes if they have 4 or more ACEs compared to someone with 0 ACEs. So they're about 12 times as likely to commit suicide, to attempt suicide, 7.5 times more likely to be an alcoholic, 2 times as likely to have ischemic heart disease. And a good summary statistic is that we know that the life expectancy of a person with 6 or more ACEs is about 20 years shorter than a person with no ACEs. And all of this has to be couched in the fact that we know a lot about resilience and protective factors. And I'm not necessarily focusing on that in this talk, but I'm sure that there's going to be more talks on that coming down the line. So we know a lot about how to mitigate this risk, but this slide is just focused on risk. So it's really clear now, we know that ACEs are a major public health issue that for a long time were not getting the attention that they needed or deserved. And we know that the toxic stress response is really a key mechanism that links ACEs to later life health. So toxic stress refers to that prolonged activation of your stress response, or what we sometimes think of as like our fight or flight response, when we're experiencing chronic and intense adversity during certain developmentally sensitive periods in childhood. So when we do experience that toxic stress response during these periods, it can actually really break down our physiological systems in ways that have implications for later life health. So I want to go back to talk about this this CDC and Kaiser study in a bit more detail. Sorry, I'm just trying to move this around. Okay, technical difficulties. So yeah, so this study was so important. It brought attention to this major public health issue that wasn't being looked at before. And it's informed so much of what we currently know about ACEs. But the study was also limited in some ways. So you can see on here, I've written out the demographics of the original study sample and also the 10 ACEs items that they asked about, which we've already discussed. And then you can see I wrote in this box, like, who was left out from this study and were there other types of adversities that were missed? So just give everyone a few seconds to think about that. So there were a lot of populations that were left out, right? Right away, I'm thinking, you know, people of color weren't well represented in this study. People who were uninsured or on Medicaid or Medi-Cal weren't well represented in this study. And there's a lot of adversities that, you know, research has shown are really important for later life health outcomes, things like racism or economic hardship or separation from family through immigration or deportation. And these adversities weren't represented in this study. And of course, these are adversities that disproportionately impact populations that weren't included in this study. So this is all to say that if we just go off of these study results to understand ACEs, we are missing an important part of the picture of adversity in health in this country. And it's now acknowledged by scientists that there are a number of other adversities that can cause that toxic stress response that weren't included in the original ACEs questionnaire. And researchers have also started to try and understand how ACEs manifest across more diverse populations. So this is a study that I did in 2018. These are some of the results. And what I wanted to do was understand the prevalence of ACEs across race and ethnicity in youth who also weren't included in the original CDC Kaiser study. So this included almost 30,000 youth, and I looked specifically at the 3 largest racial and ethnic groups in the US, Black, Latinx, and white populations. And I looked at cumulative ACEs scores and individual prevalence of individual exposures to different ACEs. And these are the ACEs that were included in the study. So you can see that I had some of those traditional ACEs as well as newer ones that have more recently been proposed, things like racism or neighborhood violence. And pretty consistently, certainly in terms of cumulative scores, Black and Latinx youth had the highest scores, followed by white youth. And then that pattern pretty consistently replicated itself for most of the individual ACEs items as well. These are tables done from a study by Peter Cronum and colleagues in 2015. And they also wanted to understand what is the prevalence of ACEs in a more diverse sample. So they looked at an adult sample of almost 2,000 adults in Philadelphia. And this table on the left, they're comparing the demographics of their sample to the original Kaiser sample, as well as the Philadelphia census. So right away, you can see that their sample was more diverse, particularly in terms of race ethnicity. They had many more Black participants. So they had 43.6% of their participants were Black compared to 4.8% of participants in the Kaiser study. And they were also more educationally and age diverse as well. And they looked at the original 10 ACEs and they looked at the prevalence in their sample versus the Kaiser sample. And they also looked at 5 additional ACEs. And these were ACEs that they came up with through a community ACEs task force. So they really were working to understand, okay, what are the adversities that are really relevant in the everyday lives of the people that we're studying? And they came up with these 5, witnessing violence, feeling discrimination, being in an unsafe neighborhood, experiencing bullying, or living in foster care. And you can see, at least for the first 3, that they were pretty widely endorsed by their sample. So 40.5% of the sample endorsed that they had witnessed violence, 35% felt discrimination, and 28% felt that they were living in an unsafe neighborhood. And then looking at the original ACEs as well, in general, this sample really had much higher endorsement. So for example, 38% of their sample endorsed physical abuse versus 10.8% of the original Kaiser sample. And 35% endorsed a household member using substances versus 25% of the Kaiser sample. All right. So the previous two slides were just examples of a growing body of work that is really showing some substantial differences in prevalence in ACEs across demographic groups. And we now know that compared to the original ACEs study, there are higher prevalence rates of ACEs in people who are low income, people of color, people who are justice involved, and people that are part of the LGBTQ+ community. And we're also starting to see how important it is to consider other ACEs that weren't in the original study, but still have that potential to cause toxic stress, particularly ACEs that perhaps disproportionately impact certain segments of our population over others. So the inequities that we see in ACEs today, they didn't occur in a vacuum. They're directly tied to nearly 400 years of policies in the United States, many of which are laid out on this timeline. And this is a timeline adapted from materials from the Center for Community Resilience at George Washington University, run by Dr. Wendy Ellis. And they really have some good resources that go into more depth on this topic for anyone that's interested. But just to give some examples, the Indian Removal Act forced displacement of Native Americans from their homelands. Jim Crow laws separated people of color from whites in schools, housing, and employment, perpetuating a discriminatory system that persists today. Redlining involved lending institutions in the US systematically denying loans and mortgages to people of color in urban areas, which generated huge disparities in neighborhood resources and generational wealth. And we now know that people who live in neighborhoods that were once subjected to redlining are more likely to experience shorter lifespans than people living in other neighborhoods in the same city. And sometimes this difference can actually be up to 20 or 30 years. These neighborhoods are also more likely to have greater social vulnerabilities, meaning they're less able to withstand natural and human disasters because of their more limited resources. Okay. Mandatory minimum and 3 strikes laws disproportionately targeted nonviolent, low-level drug offenders of color, which contributed to mass incarceration and racial and ethnic disparities in incarceration today. And then finally, Prop 187, this was a ballot initiative in California to prohibit undocumented immigrants from using non-emergency healthcare, public education, and other services. All right, so I'm gonna pause and give everyone a second to read these quotes on their own if they wish, and do a time check. Okay. So I think these quotes are speaking to how history's legacy continues into the present. And what I want to talk about next is examples of how these policies that we just discussed impacted the lives of people today, including their exposure to ACEs. So having a family member incarcerated is an ACE, and our socio-political history has led to mass incarceration and racial and ethnic inequities in terms of how people get treated by the law. So you can see the disproportionate statistics on the slide. And in addition to those, I have a few more. So a Black person is 5 times more likely to be stopped without just cause than a white person. And we also know that Black and white people use drugs at similar rates, but the imprisonment rate of Black Americans for drug charges is almost 6 times that of whites. And 65%, so 2/3 of Black adults have felt targeted because of their race by law enforcement. And approximately 35%, so more than 1/3 of Latino and Asian adults have also felt targeted because of their race. We also see persisting racial and ethnic disparities today in employment, income, and wealth. So some people do consider economic hardship on its own to be an ACE. And we know that economic hardship means families have less time and fewer resources and more stress, all of which increase risk for child neglect or other ACEs related to household dysfunction. There's also large racial ethnic disparities in access to physical and mental health care. So in general, people of color are less likely to be able to access care. And when they do access it, it's less likely to be of good quality. So of course, this increases the likelihood of ACEs in racial and ethnic minority families, including, for example, having a family member with mental illness. Death of a caregiver is also an ACE. And there's not only disparities in healthcare, but also health outcomes, of course. So on the left is an infographic showing increased risk for various poor health outcomes for a Black person compared to a white person. And on the right, we can see the disparities in death rates from COVID, with Black people being hardest hit, followed by Native American people, and then Latinx people. And I want to spend a bit more time on COVID because it's so relevant to all of our lives. We're living through it. And it's such a clear example of how communities and demographic groups that have been systematically marginalized bear the brunt of a public health crisis. So first, these communities are more vulnerable to COVID for a host of reasons, like being disproportionately essential workers and living in communities where there aren't as many resources, including resources to be safe. And we know that ACEs, which I've now shown are more common among people of color, they are related to greater risk for heart disease and diabetes and kidney disease and obesity. And all of these diseases are diseases that predispose someone to a more severe COVID-19 disease and then also increased risk of death from COVID. So COVID is going to increase exposure to ACEs, and we can see some examples here. There's concerns about increasing challenges related to child mental health, poverty, food, and housing insecurity. There's also more stress in homes due to increasing need for childcare and a lack of ability to do childcare. There's gaps in education that are growing, and domestic violence and child abuse and neglect we know are also increasing right now. So I've just shown a lot of data, but I want to bring us back to remembering how that actually looks and feels in the everyday lives of people. So if we just step away from the numbers and the charts and just look at what's happening all around us, it's impossible to ignore how the historical legacy of different levels of racism and discrimination is playing out in the present. So Ta-Nehisi Coates said, "All of our phrasing serves to obscure that racism is a visceral experience. It dislodges brains, blocks airways, rips muscle, extracts organs, cracks bones, breaks teeth. You must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions all land with great violence upon the body." So this is just a collection of pictures and headlines from recent news, just to exemplify what I'm talking about. And I think most of them are self-explanatory. The bottom right image is kids who are staying at an immigration detention center. So all of these current events are depicting ACEs themselves or events or actions that contribute to ACEs and poor health in communities of color. So I hope that now I've managed to lay out or reiterate how ACEs emerge in a socio-political context that's really grounded in our country's history of racist policies or structural racism. And I argue that we need to always keep that in mind when we talk about ACEs, because our understanding of ACEs really started with trying to better explain chronic illness. And we now understand that ACEs are a root cause of health and disease. But if ACEs are the roots, then structural racism is really that root, is really the soil or the context which allows these ACEs to occur and proliferate. So we have to be able to understand this whole picture if we really want to see all the different points at which we can intervene. So with that being said, we need models of ACEs that acknowledge and account for the influence of both history and larger structural factors. So I like to think of it in a socio-ecological and transactional way. Socio-ecological meaning that a child is nested within different environments of influence, all of which have factors that can impact their development. So here I've written out family, community, and societal. And at the family level, when we think about different adversities, it's really mostly those ACEs that were covered in that original CDC Kaiser questionnaire. Things like physical and sexual and emotional abuse, or family mental illness. And then the community level includes some ACEs that people have started to add to questionnaires or have started to call for further study, things like racism or community violence. And then the societal level is really encompassing factors related to the structural inequities that we've been talking about, things like a discriminatory justice system or barriers to healthcare. And this model, I think, also needs to acknowledge the role that history plays in creating these various adversities. And then there's this transactional piece, which means we acknowledge how items within each of these environments impact items within other environments, and they feed and build on one another. Okay. So part of seeing the whole picture of ACEs and health is considering how our ACEs practice might inadvertently cause harm, particularly for historically marginalized populations that we know are more greatly impacted by ACEs. So I want to share some concerns that I've thought of, and please feel free to type in the chat other concerns that have perhaps come up for you. And here I'm talking about mostly this big plan or practice that's currently happening where across the state of California, we're starting to screen for ACEs in primary care. So the first concern that comes up is, could screening for ACEs possibly increase stereotyping or negative expectations in the healthcare system or other systems? And this wouldn't be the first time that a new practice implementation meant to improve care actually harms vulnerable populations. So for example, some medical centers use treatment algorithms. And to quote from this article, an algorithm determines which patients require the most intensive medical needs. Because of the pre-existing data that informs the program, the algorithm will conclude that Black patients are less sick because they have been historically provided less care and thus have a lower risk score. As another example, a study published in 2016 found that a majority of medical residents believe that Black skin is thicker than white skin. And a substantial number of residents that were surveyed in the study also thought that Black nerve endings were less sensitive to pain, which of course contributes to discrimination in treatment of pain, including pain medication prescriptions. Okay. Another concern is whether this huge influx of screening that's underway might increase separations of children from their caregivers, particularly through referrals to child welfare. And of course, sometimes this is a necessary and needed step, but there's so much that we don't know about how this large unrolling of screening is going to impact referral centers, including child welfare, including community mental health agencies, as well as other types of places. So it's really possible that they could be overwhelmed or underprepared or under-resourced. And we know that that can lead to staff dissatisfaction or burnout or turnover, and a lack of referral centers' abilities to meet the needs of the families that are being sent to them, of course, is going to result in more inequitable treatment across the board. So another concern is, could screening for ACEs actually increase stigma and shame in communities that we know are more disproportionately impacted by ACEs? So in the past, we've seen that the same problem can be treated differently across different racial and ethnic groups. For example, the way that drug use has been criminalized in Black and Brown communities and medicalized in white communities. So this article describes racial differences in how crack versus heroin was treated by society, saying the racial double standard has been hardwired into the nation's drug laws and criminal justice system. When it comes to heroin and the prescription opioid epidemic, the priority is saving lives. In contrast, the remedy for crack was mass arrests and stiff prison sentences. And there was another quote provided in the article from the special agent in charge of the Drug Enforcement Administration in New York during the 1980s war on crack. And he said, if the addicts were predominantly white instead of Black, we would have offered them treatment as we do now. Okay. A last concern is, could screening for ACEs breed mistrust or discomfort between patients or providers, which is, of course, the last thing that we want. But it's beyond fair for communities of color to be suspicious of the medical community. There's countless examples of how they've been misused by medicine in the name of science in our history. So one example is John Marion Sims, known as the father of modern gynecology, but he actually made all of his scientific progress through doing testing and experiments on enslaved women who were not under anesthesia. So this article talks about how Sims caused untold suffering by operating under the racist notion that Black people did not feel pain. His use of enslaved Black bodies as medical test subjects falls into a long, ethically bereft history of medical apartheid that includes the Tuskegee syphilis experiment and Henrietta Lacks. Okay. So I wanted to check the chat and see if anyone had typed anything in, but I don't know if I can see the chat right now.
So Dr. Liu, we have a question.
Yep.
From David Dooley. David, I'll go ahead and read the question, and then if you want to add to it by unmuting yourself, you're more than welcome. The question is, most, if not all, of the 10 original ACEs are associated with unsupportive and harmful parenting. This suggests that the most important lesson from the ACE study, and the one that is not being addressed, is that many ACEs can be prevented with public health approach parenting education.
Yeah.
Perhaps national parenting education campaigns akin to the smoking and seatbelts campaigns of the past. Perhaps national multimedia messaging that teaches parenting behaviors and practices generally recognized as supporting the health development of children. Do you agree, disagree?
Yeah, I agree. And actually, I think I'm familiar with David Dooley's organization. I've seen it. And I think, yeah, I think parenting skills is a huge resilience and protective factor for ACEs, and can mitigate the impact of many different types of ACEs. So I definitely think that it's worthwhile for us to think more about how we can promote positive parenting practices.
Excellent. David, did you want to add anything to that? Okay.
Okay.
Going
Great.
once. All right. So we have another question here. How can we create an unbiased algorithm? Are you familiar with ways in which we can actually use an algorithm that would be amenable to all people?
I think, I mean, I'm no IT computer systems expert, but I think the first step is by critically questioning every new practice implementation that we take on. For example, like the ACEs screening, and educating ourselves on how these things have gone wrong before. So I think that's relevant to my next slide. So maybe I'll move through, and then we can come back to it maybe in the questions time. So let's see, just to go back. Yeah, so exactly what I was saying. I think we need to now be thinking about how do we mitigate these concerns. And I do think that the first step, and a huge step, is acknowledging them and remembering them in our ACEs work so that we can avoid as much as possible repeating these same mistakes or new variants of these mistakes. And this is part of what it means to take a culturally responsive approach, which I define as acknowledging racism as a root contributor to existing disproportionality in ACEs exposure and later health outcomes. And then in our ACEs work, recognizing and endeavoring to address the multiple barriers to health and healthcare faced by historically marginalized populations. So how do we do this? First, we keep learning. And what I mean by that is that we stay open to learning and continually seek out new education about other practices and innovative practices, and we share with one another. So this forum, I think, is actually a perfect example of that. And you'll see that I've invited all of you to type in the chat ways that your organization perhaps has implemented practices to be culturally responsive, because I know we have a wide range of expertise in this conversation right now. So I think it's also really important to assess cultural relevance and appropriateness of every single initiative. And of course, we're talking about ACEs right now. So all of our ACEs related initiatives. Always be asking, is this initiative meeting the needs of the community I'm trying to serve? Is there anyone who might be inadvertently left out, or even worse, harmed by this initiative? We can focus on developing and implementing policies and practices that reduce racism and promote equity. And I think, we really have to devote resources to these projects and create teams of experts to help us do this work. So part of this work is, I believe, community-wide educational initiatives that can raise awareness of ACEs and implications for marginalized communities, like what we're doing right now, and really bring in that resilience, strengths-based protective factors conversation as well. And, talk about and consider what are the culturally specific sources of resilience in this community that we can really build on. And then part of this also means that we work to mitigate structural barriers to care and well-being faced by these communities. And I think we can do this in a lot of different ways, but these approaches are always strengthened by interdisciplinary collaborations. Community partnered and community driven approaches are always, I think, really a cornerstone to this work. And one great way to do that is through forming a community advisory board. And then finally, cultural humility is, I think, really essential to always be trying to cultivate both within ourselves and within our organizations or within our system. So I put a definition of cultural humility on this slide, but essentially, to me, it means being aware of your own cultural background and really taking the time to reflect on your experiences, your biases, and your privileged and marginalized identities. Working hard to be comfortable and curious and respectful and humble when it comes to thinking about cultural differences between yourself and others. Understanding how oppression and biases affect yourself and the work that you do, as well as others. Striving to proactively address racism and bias when it occurs. And then I think another really critical piece is recognizing that trust is always earned and never owed. So whether it's a relationship between coworkers or between a boss and an employee, or a provider and a client or a patient, by nature of the relationship, trust is never owed. And we always have to work for that to establish it. Okay, how are we doing on time? Great. So I want to end, we're moving towards the end of this discussion, and I want to end with describing some approaches to ACEs screenings that I've actually been a part of, and talk about how there's features of these programs that I feel are really attempting to infuse cultural responsiveness into the process. So the Santa Barbara Resiliency Project, it's actually a study partnership between UC Santa Barbara, the Santa Barbara Neighborhood Clinics, which are federally qualified community health centers, and CALM, which is a community mental health agency. And it's a research study and also a screening and intervention program. So they're testing an ACEs screening and prevention program for young children under the age of 3 and their parents. So they get screened, both parents and child get screened for ACEs at their well child visit. And if they qualify for being at risk for toxic stress and they want to participate in the program, they get assigned to one of 2 preventions or a waitlist control group, because we're trying to understand, is this prevention program really effective? So of the 2 different prevention programs, one takes place in the home. So a behavioral health provider will come to the parent and child's home and work with them for several visits. And then the other intervention program takes place in the clinic. So we're not only just testing, is one program effective, but we're really trying to understand what works best for this community. Is it easier for parents to have someone come into their home? Is that overcoming more barriers to care? Or is it kind of uncomfortable for them to have someone come into their home? And would they prefer to actually just see someone in the clinic? And we try to make it as convenient for them as possible. So we always schedule the behavioral health visit right after their well child visit that they're already coming in for. And we were really thoughtful with the design of this prevention program. So it was designed partially based on evidence-based interventions for trauma exposure, but we also did a community-based participatory research process, meaning that we really designed this intervention with and for the community. So we had a lot of community forums and focus groups with key stakeholders, including parents, teachers, youth, police, faith-based organizations, and others, to try to understand what are the features of this intervention program that are needed for successful implementation within the clinics, and that will really help the community.
On that note, Dr. Liu, there was a question about child health services and best ways to avoid that kind of connection. What kind of conversations might somebody have so that child health services wouldn't have to be involved? Would some of the ways that you just discussed help, or can you speak a little bit more about child health services?
Yeah, by child health services, do you mean like CPS?
Yes.
Yeah. Well, I think that probably could be a whole nother discussion, but I think that that's something that really makes people nervous, is the thought of having to do mandated reporting, or perhaps getting child welfare services involved. And sometimes, and I don't know if there's anyone on the call that's actually from child services that would want to speak to this, but I think sometimes they get a bad rap, and their sole purpose is definitely not to separate children from their parents. In fact, what they really want to do is strengthen families and help keep families together. And so I think it's important to get as much information as you can if you're doing screening, and there's a concern that might trigger a mandated report. And then of course, if you have to do a mandated report, you have to do a mandated report. But I think one of the things that's so essential in doing that is doing it in partnership with the family, and letting the parents know, and actually calling child services together with the parent. And I think there's a way to structure that conversation to say, like, that this is really about getting you more support and more access to resources, because that is really what it's supposed to do. And I think, yeah, I think I would leave that conversation there for now, if that answered the question.
Yes, thank you.
Yeah, thank you. That's a really good question. And I think it's a concern for a lot of people. Okay. So I want to talk about the another feature of this project, which is the role of the Wellness Navigator. This was a really important feature. So the Wellness Navigator, also sometimes called a community health worker, this is someone that doesn't have formalized health or mental health training, but rather they have expertise in connecting with community members. So their goal is really to provide culturally and linguistically appropriate connections to health and social services. So in addition to coordinating families' involvement in this study, they also assist them with accessing resources to address other stressors in their lives. For example, food access or income or employment or housing, transportation, insurance, social services, really like a huge range of resources. And so by doing this and by having a wellness navigator in this program, I think that this model of care is recognizing that for families to be truly engaged in a toxic stress prevention study, we first need to address other barriers to care that they might be facing, because they're not going to be able to engage or benefit from a parenting program if they don't know where their next meal is coming from. So it's like if we think back to that plant model of health and ACEs and structural racism that I showed a lot of slides ago, I think that the screening and prevention piece here is addressing ACEs, or the roots of the plant, but the wellness navigators are really helping to address the structural barriers to treatment engagement that are embedded in that soil around the plant. So I have two quotes. This is from a study that was recently published by Dr. Maya Barnett. She interviewed people about the role of the wellness navigators in this project. And one wellness navigator said, "We aren't just here for physical illness. We're here to figure out other factors in your family system that are needed to support your family in a positive way." And then a pediatrician spoke about the role of a wellness navigator with a family where the father had just been suddenly deported. And she said, the mother had to go get a job and get childcare for all of her children. And the first person she called was the wellness navigator, because she really doesn't have any other resources here in the community. She doesn't have a family that she can ask for help. So the wellness navigator in this case was really a lifeline for this family. Okay. So the last model that I want to talk about is this ESOC collaborative practice model. This is another model of care involving ACEs screening that I had the opportunity to be a part of when I was working at a hospital on the East Coast. And really this model was launched to improve recognition of childhood trauma and mental health needs and reduce healthcare disparities in an urban safety net healthcare system that served a huge number of highly socioeconomically and racially, ethnically diverse children and families. So the screening would take place in the pediatric office, because that's often the first and sometimes the only point of contact between these patients and the healthcare system. So that's really a good way to reach a wide range of people. So the way it works is when mental health concerns would come up in the pediatric office, pediatricians would refer these patients to this specialized collaborative practice team, which was made up of the pediatrician themselves, the CCM, the clinical care manager, who's a licensed clinical social worker, a family support specialist who is a peer-to-peer parent with lived experience parenting a child with mental illness, and a child psychiatrist. And so again, the family support specialist role was really unique and crucial here. So wherever possible, they would share a similar cultural, linguistic, or community background with the family that they were working with. And they were really there to support the parent in what they were going through, because they had a shared experience with a child with mental illness. So after the pediatrician refers the child, the team would conduct a multidisciplinary evaluation, including an ACEs screener, a clinical interview, and assessment measures. And then they would create a shared treatment plan, facilitate mental health referrals and connections to community resources, and continue to serve as a consultative resource to the family's pediatrician and to the family, and help them maintain connection with community agencies that they were referred to and follow through with those referrals. So it's really kind of like a wraparound team. And because it's a multidisciplinary team sharing this treatment for the child, they're really better able to meet all of their needs, including barriers to care, like the economic stressors that I was mentioning in the last example. And sharing these families as a team helps to reduce burnout and compassion fatigue, or maybe even vicarious trauma, because doing trauma work with multi-stress families is really, really hard work. So being part of a team allows providers to support one another through this process, and then therefore provide better quality patient care. So I have a forthcoming research paper on this model where I did some interviews with the team, and I want to share 2 quotes about the role of the family support specialist in this model. So one provider said, in terms of attuning to our diverse and complex population, we are asking the parent to disclose really sensitive information about exposure that their child received, oftentimes in their care. I think that FSS is so crucial to that, because when it's questions about mental illness, when it's questions about depression and suicide, when it's a question about substance use, it does help if the parent has met a member of the team who they feel like is in their corner, no matter what the answer is. And then another provider said, the backgrounds of the family support specialists often match the families that we were working with, and families felt very comfortable engaging with them. The amount of communication between them was more than they had with the social worker or the medical provider. They were able to communicate with the whole team through having an FSS. So really, I think that the quality of services related to ACEs screening and treatment and a family's engagement in these services were both greatly improved because of the thoughtful design of these programs that included elements that were addressing structural barriers to care and cultural differences in needs faced by these families. So that allows us to better address ACEs among populations who are most impacted by them. So on that note, I'm going to move into this section and I will stop sharing. Thank you.
All right, thank you, Dr. Liu. I'd actually like to ask everybody to unmute yourself and give Dr. Liu a round of applause. Thank you, Dr. Liu. Thank you.
Thank you.
Yeah. So often on Zoom, everybody stays muted, and it's nice to get a little feedback from this.
It is.
So
I appreciate that.
Yes. So now we'd like to open it up for questions. We do have a question starting off from Tensha Cesares. Tensha asks, has there been conversation around implementing ACEs education into our current education system, such as high school health and psychology courses? The initiative may help current parents, caregivers get access to therapeutic parenting programs. However, I wonder about interventions at a much earlier stage, particularly because of a high rate of teen or young adult parents.
Yeah. I think that that is a brilliant idea. I don't know of any initiatives in particular that are trying to teach about ACEs in school. I know that some people have talked about screening for ACEs in schools, which I think brings up a whole range of questions and concerns. But I think that schools are such a good way to reach a large youth population, that sharing the ACEs information that way is a really great idea.
Dr. Liu, this is Patty Havard. Thank you so much for your presentation. And hi, George. We are now, I just finished submitting a the ACES planning grant. And one of the things that we incorporated in our grant proposal is training of our medical residents on ACEs, toxic stress, et cetera, and best practices in trauma-informed networks of care. And I think the previous participant asked an excellent question. But I think that just like substance opioid use disorders, the curriculum within the medical profession during the professional schooling is just lacking. And so there's more push now to do that. And I think that's a great idea to incorporate training, especially in medical schools, et cetera. The question I have for you is that you talked about FSS and we talked about different navigators. There's now so many different navigators. We have the substance use navigators. So you're adding layers and layers of complexity instead of being efficient. And how can we provide a process of development of a navigator who's able to handle the ACEs, the substance use, et cetera, instead of continuously handing off to other navigators?
Okay, so you're asking, like, do we need to have, right now it feels like we have to have specialized navigators for each of these roles?
Yeah.
Yeah. That's a really interesting question. I mean, I would argue, again, at least in my, in the studies that I've worked on, like the navigators, their role and their expertise has really been about connecting with the families and providing linkages to care. So they themselves don't necessarily have to be experts in opioid disorders or ACEs. It's good for them to have general knowledge about it, but I wonder if there could be a way that that role could be shared across those different disciplines with a network of navigators within a healthcare system. But I think, again, yeah, what you're speaking to is like how difficult it is to implement new and novel program designs within systems that are well established. So I think in that sense, it really requires buy-in and commitment from the people in charge that are able to make those decisions.
And that's my concern, because with the COVID pandemic, the economic health of healthcare systems is just taking such a negative hit across the nation.
Yeah, I agree. Thank you for that question and for that comment, and for providing your comments about education as well. I think I've definitely heard more about education within healthcare systems, and I think that that's also crucial. And that curriculum would obviously look different than like curriculum for a high school student. I would say that I know that they're doing a lot more like social emotional health curriculum for kids in school. And I think the ACEs awareness stuff could be easily tied into that. So maybe that would be a way in.
Thank you, Patty. So glad you made it. Next is a comment. I'm wondering, April, if I could get you to unmute and share your comment about the movie Paper Tigers. No, we can't hear you. Can we?
Can you hear me now?
Yes,
Yeah.
yes, you're good. Thank you, April.
Thanks. So Paper Tigers is a film that came out, I think, in 2015 or 16, and it features a local high school in Walla Walla, Washington, who begin teaching their students about ACEs and also train their instructors and teachers and their support staff about ACEs. And then they begin to see how that instruction and that knowledge impacts both services and instruction to students, but also how it helps and supports students who are going through a difficult time. It's a really great film. And there's a whole kind of discussion guide that is available on the internet, I'm pretty sure, because I've used it with my staff. And so for folks who are interested in how this could look in a educational setting, I think that's a really great film to look at. And I also think that this really does require a whole level of changing teacher education as well, because teachers who are ACEs aware and also focused on resiliency are going to come into their classroom and interact with students very differently, I think, once they become more aware of that.
Excellent. Thank you, April. I appreciate that.
Yeah.
And looking at the time, one of the things about this network of care that's really important is that we are a network and that we want to connect people. And so on that note, I'd like people to just popcorn style unmute yourself one at a time, introduce yourself, and share where you're from, what organization you're from, please. So I'll go ahead and let you start on your own.
I'll start. Hello, everybody. My name is Clarissa Ravello, and I'm the first 5 program officer here in Kings County.
Excellent. Thank you, Clarissa, and thank you for jumping in, being the first one. Thank you. We're good to see you as well. And just as a note on that, when you introduce yourself, if you do feel comfortable to start your video, go right ahead, Gladys.
Hi, everyone. My name is Gladys Lopez. I am a mental health counselor with NAS Lemoore Fleet and Family Support Services.
Hello, my name is Sarah Flores, and I am the program coordinator for West Care Adolescent Services.
I'm Patty Havers, research development specialist, but prior to that, I had 32 years of clinical translational research, and one of the interprofessional collaboration that I had the privilege of working was to start the HIV high-risk pregnancy clinic at The Ohio State University. So I'm really looking forward to this because it's very similar in framework for the ACEs as I did for the HIV high-risk pregnancy clinic.
My name's Jose Heredia. I'm the ACEs Aware Project Coordinator at the Child Abuse Prevention Council. I'm actually out of San Joaquin County. I'm one of the other grantees where I'm in charge of facilitating network of care here in San Joaquin County as well.
And thank you for joining us today, another ACEs Aware grantee. Thank you, Jose.
Hi, my name's Hortensia Casares. I am a social worker with SpearNet, which is a foster care and adoption agency. So I'm a social worker in the foster care system. I specialize working with post-adoptive families.
Hi, good afternoon, everyone. My name is Carmen Becerra, and I am with Sequoia's Adult Education Consortium. I'm a navigator, an adult education navigator. So I work with the adult schools in Kings and Tulare County.
Hi, everyone. I'm Teresa Alvarado. I stepped away for a few minutes, and I work for Aetna, the insurance company. And I wish you all happy holidays. So glad that I was able to join the call.
Thank you, Teresa, and thank you for those holiday wishes.
I forgot to mention, good luck to you guys. We sent a letter of support. I hope everyone else had the opportunity to send a letter of support for our continued support of the collaboration that we're on today. A wonderful speaker.
Thank you, Teresa, and I appreciate you mentioning the network of care support that you're giving us. We do have a big grant. I know Patty Havert is somebody else who is working on that is due today, and so everybody's attendance is very much appreciated. Your time is very much appreciated. We are building this network of care, and we will have much more information about how that looks in the coming months. Before we move on to Kings 211, I'd like to see if anybody else has not introduced themselves.
Hi, oops, here. Hi, my name is Sarah Sorensen. I'm part of Lemoore Naval Air Station New Parent Support. It's nice to be on here. I missed the last one, so I'm glad I could join this time.
Hi, I'm Araceli Castillo. I am here from Adventist Health. I am a grant writer in the Central Valley, so I serve a variety of different facilities within that region. And I would turn on my video, but my internet has been so shaky today. I'm scared I'm going to get kicked off. So I just really appreciate being a part of this, really appreciate the presentation as well.
Awesome. Thank you, Araceli. I know how the internet can be. We do have an introduction in the chat from Amy Brisky, who's the Quality Assurance Clinician for Kings County Behavioral Health and also ACES certified. Thank you for being here, Amy. Is there anybody else that has not introduced themselves? Great. Okay. So I would like to, at this point, turn this over to Erica Lopez. I'm doing two things at once here. I hope you can see my screen. Erica Lopez is the 211 coordinator at Kings United Way. Erica, if you'd like to unmute yourself, and everybody, I'd like to invite you to give your attention to Erica, who will be talking a little bit about 211 and the information that it entails.
Thank you, George. Good afternoon, everybody, and happy Monday. The first picture here is Nanette Villarreal, which is Executive Director of Kings United Way. Again, my name is Erica Lopez. I'm the 211 coordinator at Kings United Way. George, can we please go to the next slide? So I am here to talk to you about 211 Kings County and a new project we are working on bringing on called CIE, short for Community Information Exchange. So 211 Kings County is a free 24/7 service. And it is a 3-digit dialing code. It gives you access to community and health and social services. For community information exchange, it's a systems change that fosters true collaboration across networks, moving towards person-centered interventions and interactions across healthcare and human services. The goal is to improve health and wellness for individuals and populations. So going into 211 Kings County, 211 Kings County is a program of Kings United Way. It is a free and confidential tool you can use to find different resources in the community, whether it's food, clothes, mental health resources, and much more. All 211 Kings County services are available 24/7 as well. And these are different ways you can access 211 in Kings County. So you can dial 211 and speak to a live call specialist. Call specialists can serve callers in over 150 different languages. As mentioned earlier, it is confidential and free to call. If someone is looking for services in Kings County, they can dial 211 and get connected to a live call specialist. So when somebody calls 211, they can let the call specialist know, the reason why they're calling, what services they're looking for. The call specialist will then search our database and provide caller with information over the phone, or can also text information over to the caller via text if the caller would like. Towards the end of each call, at the end, a call specialist does ask the caller if they would like a follow-up call. If the caller agrees, that is where me and my team come in and follow up with callers. You can also text your zip code to 898-211 to receive information on resources and get connected to a live call specialist. So when you text your zip code to 898-211, you receive an opt-in message asking for age, gender, and reason for contacting 211 Kings County. The call specialist will then receive that information and communicate with you via text. We also have where you can search our database by visiting 211kingscounty.org, where you can either search by text or click on different categories that will then give you information on different programs we have listed on our database. On our website, we also have a food calendar available, and that is updated on a monthly basis. It gives information such as hours and location on local food pantries, food distributions, and meals served in Kings County. We also have live chat available where you will get connected to a live call specialist on our website in case you're having some trouble finding a resource. You can also search information on our mobile app called 211 in Teleful. And 211 in Teleful is available in both English and Spanish, very similar to the website. It displays different categories. When you click on a category, you'll then be taken to a list of subcategories. And then you click on the subcategory, and then you can get information on different programs in Kings County. So the mobile app, you can share information via text or email, and you can also save resources to go back to at a later time when you favorite a resource. In the next slide that we will be going into, there is going to be a short video demonstration on how you can use the website. Search through our category menu. Click on the category of your choice. Information on services in our database are available in both English and in Spanish. Get information on a service such as description, phone numbers, location, hours, and program delivery. Visit 211kingscounty.org. Okay, so that's just a little short video of how you can access our website, 211kingscounty.org. I will now be going into a new project we are working on. We're super excited about, and it is the Community Information Exchange. So the Community Information Exchange is a community-wide referral system that facilitates connections across multiple agencies and links patients and their families to needed services. So we'll be, it's a resource database. It has closed loop referrals where we can share client level data. In this slide, it gives you the core components of a CIE. The core components of a CIE are network partners, shared language, resource database and bidirectional referrals, technology platform, and data integration. And the combination of these will allow network partners to access a database, share information, make referrals, and access shared client records, enabling partners to collaborate and coordinate with each other. So in the CIE, we are focusing on multiple social determinants of health to really understand what the person situation is, as well as what the person is going through on a continuum, to understand how to address their needs. And this helps create a person-centered system of care, allowing partners to share data and manage closed loop referrals. There is a lot of benefits to the CIE, and for clients, the clients will not have to share their story to multiple agencies, not having to reshare their story to different people, and will be able to successfully connect to services. Individuals will also have better access to care and support they need to improve their health. And for service providers, all that information will be shared with each other, and they'll be able to ensure that all the individuals' needs are being addressed. So overall, that is what the community information exchange is. After this presentation, I will add my my email to the chat box. Please feel free to reach out to me if you have any questions. Thank you.
Excellent. Thank you, Eric. I really appreciate it. Lastly, we have two things before we wrap up our session for today. It is almost time to go. We have our evaluation survey. Karina, if you could put this evaluation survey in the chat box, that would be great. Please, I really encourage you to take the evaluation. I believe it will be sent to you, to everybody who attended here, in a email format, but we'll also try to get it in the chat box. The evaluation survey asks a few questions about the Network of Care meeting. We are trying to get this data. It's really important, and it takes less than 5 minutes. It's very quick. And I beg, I plead, each and every one of you, please do take a moment to fill out our evaluation. We really need it. It is important. ACEs Aware is part of the process and is asking for this information. So again, your time is very important, and your taking attention to this evaluation is very important. So thank you in advance for doing this. I really appreciate it. And lastly, we have our Network of Care, the Power of You, Save the Date slide. And in case, for those of you who are planning and putting into your calendar your 2021 dates, here they are. We've got our next meeting on January 19th, 2021. And they are the third Monday of every month from 2 to 3:30. We felt this time was the best time available. Let me just pull up, I have a couple notes here. February 16th is the next one. Our event in January is going to be called Reconnect for Resilience. It's by Tammy Blackard Cook. Got her name right there, Blackard Cook. Tammy's a licensed clinical social worker specializing in trauma therapy with adults. She holds a master's degree in social work from the University of Chicago. She trained with Brene Brown to become a certified Daring Way facilitator in Brown's The Daring Way work. And in addition, Tammy is a certified practitioner in the Trauma Resiliency Model, TRM, which is a mind-body approach that focuses on the biological basis of trauma and the automatic defense ways that the human body responds when faced with perceived threats to self and others. So it's going to be another exciting talk. January 19th, again, is that date. Make sure to put that in your calendar. Register for that in advance. I believe we are sending out pre-registration emails and reminders. Keep an eye open for us. We are not only sending out emails directly to people, but we are also advertising on ACES Connect on all our events. I want to remind you, if you are a provider, that we have a peer-to-peer session, which is our next peer-to-peer session is January 8th. It's at 7 a.m. It's every month on the second Friday of the month. Dr. Liu will be back to discuss ACEs screening. So I'm very excited about our next peer-to-peer workshop, and I hope you can make it. Please register in advance for all these sessions. Lastly, and we're right on time, we have a raffle. So what I'm going to do is I'm going to turn this over to Cameron. Cameron is going to give us a quick spin of the names wheel, and we would like to see who is going to be the winner of a special prize. We are sending out gift boxes to everybody who attends our Network of Care. I know it's not quite in time for Christmas, but you will be receiving a gift box. We're excited about it. And let's see who wins the first raffle. Cameron, if you want to press spin and let it fly, we'll see who wins the first prize in the raffle. Sarah F. Sarah, are you here? Sarah Flores, yes. If you can unmute yourself and say hello, Sarah.
Hi, thank you. Exciting.
Yes, yes, you're excited. So what in your gift box, Sarah, you will have a special additional gift item for this raffle.
Perfect,
So we'd like to You bet, you bet. Thank you for coming, and thank each and every one of you for coming. If you have not seen the announcement in your email, we are sending out boxes to everybody who does participate in our network of care. In our gift boxes, they will be a number of fun, interesting giveaways, swag items for being a network of care member. It's our way to say thank you. It's our way to say stay connected, and it's our way to just let you know about that this is really a family. It's really a way to connect. So on that note, we are closing up this event today. I'd like to thank you all for coming. Thank you for taking the time. Thank you, Dr. Liu, for your excellent presentation. Thank you, Erica, for giving us more information on 211. And thank you, Karina and Cameron, for being our awesome production team. This is great. I really appreciate it. And for everybody that's here, if you'd like to stick around and ask Dr. Liu any questions, or ask Erica, or have any questions that you'd like to ask as we depart, we will be open for this room. This chat room will be open for a few more minutes. And if you'd like to connect with somebody or just say a few words afterwards. Otherwise, on that note, I would like to thank you all for coming. I hope you have a wonderful Christmas. Christmas is coming up this week. Haven't said enough about Christmas, but we wish you the best of holidays and hope you have a wonderful Christmas, however you do. Maybe a lot of you will be Zooming for Christmas. But however you celebrate this year, I hope it's a warm one. I hope it's a loving one. And we look forward to seeing you in the new year, connected and healthy. Thank you all for joining us today.